I'm so excited to welcome back to Direction Not Perfection, Dr. Nicole Lovett. She was born and raised in Winnipeg, Canada, graduated first class double honors with a Bachelor of Science in both biochemistry and physics. Thereafter, she can currently earn both her MD and PhD in pharmacology and therapeutics, specializing in insulin resistance, metabolic syndrome, pregnancy, and Dr. Lovett opened a medical clinic called Firefly Medical Group that offers customized medical care specific to treating symptoms and hormone problems. Dr. Lovett's high degree of expertise in drug science and research, as well as her advanced training in both bioidentical hormones and aesthetics, make her a first class provider in this space. And this is why I feel so spoiled to not only have you back, but this is your third visit with us on our show. So welcome back, Dr.
Thank,
Lovett.
thank you. Happy to be here.
Yay. Yes. Oh my goodness. I feel like you're becoming a regular. We just need a regular day for you. Um, so I wanted to start here and just kind of prep our listeners that you and I do have two prior podcasts together, and they're called Hormone Pathways in the Light Bulb Moment and Insulin Resistance Demystified. And the reason why I want to make sure we throw that out to the community, we're really trying not to just hit the repeat button and talk about what we've already talked about. So those are kind of like setting the stage, layering. I highly recommend go back and listen to those. They're on YouTube and podcasts in general. And then today we're going to do something a little spicy and work our way backwards through this whole hormonal talk. And start with, because this is a lot of my community, but seasoned women, maybe the women without a uterus, maybe the women who have been decades outside of they've been through menopause years and years ago, and are hormones still appropriate for them? So I want to kind of bring you in on this. Because you know this, but again, like a lot of my community is looking for weight loss. And one of the reasons why I feel like you're this missing puzzle piece, Dr. Lovett, is because when we're talking weight loss, it feels like some of these women can really be working hard and giving it their all, and yet they're stagnated in their weight loss. They're maybe even gaining weight, or they're just so frustrated with the slow and steady versus like there's just it's such a hard climb for them. And which always brings up the topic of or what are we missing? Do we need to be talking insulin resistance? Do we need to be talking thyroid? Do we need to be talking cortisol levels? Do we need to be talking estrogen? Like, holy cow, there's this whole plethora of other things out there, which is your expertise. So I'm going to just start with this. But do you feel like when we're having these conversations, is there an age window on hormones where like we could actually not be worrying about that piece when we're talking weight loss or health in our 60s, 70s, 80s?
So, I mean, one of the drivers of insulin resistance as we age is the loss of those youthful hormone levels and the normal hormone signaling we have when we're young because we have young receptors. And so, in my experience, you hit a glass ceiling when you're 50 up and up as a woman, especially if you've gone through menopause, where you can try as hard as you want. You can do all the macro counting, all the calorie restriction, all the exercise, and you're going to hit a glass ceiling and you're not going to get the full remission of your insulin resistance without optimizing your hormones.
Hmm.
So in terms of there being a magic age where that isn't important anymore, sometimes I get asked that question, what age should I stop my hormones? And that should be the day that you are being buried at your funeral, because up until that point, you're still going to benefit from them.
Okay, and there's no watch out factors or like, why do you think people are so hesitant later on in life to even consider hormones?
There's a lot of misinformation. 25 years ago, there was a big trial that came out, the WHI trial, approximately 25 years ago. And unfortunately, it was misinterpreted and misrepresented. And it was studying synthetic Premarin, which is pregnant mare's urine, a synthetic estrogen, and Provera, which is a synthetic progestin. And unfortunately, they threw the baby out with the bathwater. They said those hormones have risks. There's a 10-year window whereby if you start a synthetic estrogen, which is not bioidentical, you will increase the risk of rupturing established coronary artery disease or plaque in your carotids, leading to a stroke or a heart attack. After 1 year on the estrogen, even if you're more than 10 years after menopause, the risks go down because your plaque starts to regress and it didn't rupture. So you made it through the first year. When you use bioidentical estradiol, which is 100% human estrogen, you don't have that 10-year window, and there's no increased plaque rupture risk for that 1 year. And so it's, a completely different animal because that Premarin is only 15% human estrogen. Bioidentical estradiol is 100% human estrogen.
Yes.
So that's where that's
So,
coming.
yeah, where that's coming from, where the fear is coming from. And when somebody says, my mom maybe had a really bad experience with they're our age and their mom was the one who had a bad experience with hormones, do you think that's the case that they were put on a synthetic versus a bioidentical?
Yes, and if they were put on a bioidentical product that was commercially available, they tend to be very, very low dose, like placebo dosing. So most women need 2 to 4 milligrams of oral estradiol to achieve healthy levels. The product might be 0.5 milligrams, and it's not very well absorbed. So these women have levels like they're not taking hormones. And so they think these hormones aren't working, but it's a dose thing and an absorption thing, not an actual hormone issue.
Okay, interesting. And so, again, speaking to our little bit older population and worrying about brain health and worrying about, if they are coming from a family history of Alzheimer's, I feel like we're starting to hear of the benefits of hormone replacement and being a preventative measure. Do you agree with this?
Yes. And so some of my patients will have the impression that hormones will increase their risk of dementia. And again, that's a misinterpretation of that WHI trial. In those women that were greater than 10 years post-menopause and had established plaque in their arteries, giving them horse estrogens could rupture plaque and cause vascular dementia, which
Wow.
means you're normal one day and the next day you have dementia. Alzheimer's is usually a very slow progression to confusion and reduced cognitive function. And that type of dementia is related to insulin resistance. They refer to it as type 3 diabetes of the brain. And that type of dementia is highly dependent on your baseline body's insulin resistance. And HRT, whether it's estrogen, whether it's testosterone or thyroid or DHEA, all of those reduce your insulin resistance and are protective against Alzheimer's.
Okay. There's all these little like boxes of why would we not be considering this? Why aren't we asking the questions? So I'm trying to break these down really succinctly for our listeners today. And then the next piece in that is osteoporosis. And do you also feel like you've seen benefit or seen bone even healing from doing hormone replacement?
Yes, and the evidence in terms of bone density is very clear. When you are in a state where you're deprived of estrogen, this is both men and women when they lose their hormones, because when men lose their testosterone, they lose their estrogen as well. Your bones start to undergo remodeling and they lose bone density. Depending on your body weight, your genetics, your age, you'll lose a certain percentage per year. If you go on estrogen replacement therapy, you regain bone density. So it's about you regain 1 year of bone loss for every year that you're on treatment. So if you have like a 60-year-old lady who's been in menopause for 8 years, by the time she's 68, 8 years on treatment, she'll have regained the bone density she lost since menopause. And then she'll start going back up in bone density, 68 and up. And so her risk of a fracture goes down. And we know that actually osteoporotic fractures carry a very high mortality, something around the ballpark of 50% of men in the year after a hip fracture will die, and 37% of the women who have a hip fracture will die the following year, which is worse than many cancers.
Great. Wow. I've never heard those statistics. That is appalling. Wow. So even let's take it another age up, just because I know that next age group's going to ask me, but let's pretend they're 80 and maybe they even took some hormone replacement. It probably was synthetic when they did it, but let's pretend they took it and then they got off of it and they've been living off of hormones for 15 years. You would still say, as that 80-year-old or 70-year-old, you should be going back on hormone replacement therapy.
If you're looking at a quality of life thing, it's
Hmm.
hands down, they will feel better, their mood will be better, they'll have better energy, they'll find it easier to maintain a healthy body weight. Estradiol also regulates your ability to balance. So in terms of your risk for falls, if you're on estrogen, you're much less likely to fall, and therefore another reduced risk factor for a fracture. So if you're an 80-year-old woman and you live independently and you have some depression, stubborn belly fat, fatigue, and you want to feel the best you possibly could, there really is not much of a downside other than you have to commit to taking it. It's a medication thing. There's also a lot less of you're 80. How many more years do you have? Is it 10? Is it 20? If you're looking at what your priority should be at that age, if it was me, it would be quality of life, not I want to take all these meds that might help me 30, 40 years from now. I want something that helps me right now.
That's such a great answer. Thank you for that. Agreed. I think you even use this term a lot on your website, but optimize to like optimize you. And isn't that right? That to feel all of our best and feel like we're the best us that we can be in this season of life, and then we'll see what we need in our next season. But thank you. That was so good. So yes, so I think you're blowing some people's minds right now as far as like what I'm supposed to be asking about estrogen or I'm supposed to be asking about hormones. And yes, no one gets cleared from this, right? Like we don't care who you are, how old you are, if you have a uterus or not. Oh, address this because why does that come up sometimes for people? Like why do you feel like they automatically take themselves off the table if they had a hysterectomy years ago?
So
Cover them.
there's a lot of providers that are not bioidentical hormone therapy trained, like your conventional OBGYNs or endocrinologists who believe if you don't have a uterus, you don't need progesterone. So if you don't have a uterus that could get uterine cancer from being stimulated by estrogen, you don't need progesterone. But in fact, progesterone, if it's not synthetic, which is the one I use, the bioidentical version, is almost miraculous at putting you into a deep sleep at night. So it basically cures menopausal insomnia. It helps increase bone density, not as powerfully as estrogen does, but it does contribute to it. It's a powerful brain anti-inflammatory and increases your brain's ability to heal and create new neuronal pathways. And it's incredibly good at reducing hot flashes and improving anxiety in women. So if you can think of every female relative above, above the perimenopausal age group, that's one of the hormones we're missing. And so OBGYNs might say, well, you don't have a uterus, so I'm not going to give you progesterone, I'm just going to give you estrogen. But you have all these other organs that are going to benefit from progesterone, and they're intended to be given together. And because when you're young and healthy, you have both.
Okay. So this actually segues into this next piece. Well, let's take the people who have gotten to the provider who's willing to do the hormone replacements and well, maybe they're not doing bioidentical. This is a question for you. What are the questions they should be asking their provider? They've been put on it. And my examples for you are should they be asking, am I on a bioidentical versus a synthetic? Should I be on a cream versus a pill versus whatever else there is out there? Like even the pellets type thinking, like what are the watch outs for somebody who's like, well, I'm on something, but I don't know if I'm on the right something.
So there's some benefits to taking them in a certain form. So the preferred form for estradiol is oral. And that's because if you take it by mouth, your digestion will send blood flow to your liver. And then the estradiol will get metabolized into metabolites that are very effective at reducing plaque in your arteries. So it causes regression of coronary artery disease and carotid artery plaque, i.e., what leads to heart attacks and strokes. So you definitely want those metabolites. If you don't take it orally, you miss out on 50% of the benefits.
Hmm.
That's one of the big questions I get from my patients. They say, well, I have my friends are on patches and they said it's better because it doesn't go through their liver. Well, it's actually worse because it doesn't go through your liver. You want those metabolites. But providers get confused between oral estradiol metabolites and Premarin, which is the pregnant mare urine or what's in birth control. When you don't have 100% bioidentical, some of those metabolites are really aggressive at eating plaque versus gentle, which is bioidentical. And if you're aggressively chewing plaque into pieces, it can cause plaque rupture. So there's a clotting risk with the non-bioidentical oral products that isn't there with oral estradiol. So that's important to be on oral estradiol for all the benefits. Now, in terms of progesterone, there's a lot of progesterone transdermally over the counter, which drives me crazy that they can sell it. Because if you use progesterone transdermally through your skin, you will not get any good blood level from it, and you will not have any of the protection. It has to be taken through a mucous membrane or through your stomach. So that's vaginal, sublingual, or oral.
Hmm.
So that's something to ask your provider. If you're on a cream for progesterone, it's not adequate. And there's been women who've gotten uterine cancer because they were on a cream and their levels were zero in their blood of progesterone.
Interesting. I almost feel like everyone I've talked to is on a patch or cream. I don't think I really talked to anybody who's on oral or or the vaginal or the some I think you said under the tongue type, right? Yeah, this is I think why people panic around this topic is because you can feel like you're close to like I'm at least doing something about it, but I'm still missing the mark.
Well, in transdermal, you still get benefits. And if you can't be on an oral estradiol, so there's a very rare number of women who get um, severe hypertension because they make a metabolite that activates their blood pressure system, and they're on transdermal. That's fine. It's better than nothing. But transdermal progesterone is worse than nothing because you think it's protecting you, but it's giving you no blood level. And a lot of providers who do prescribe it are using salivary or urinary metabolite testing, like the Dutch test. And those levels do not correlate with your blood level. And so you're actually not getting any progesterone if you use it through the skin.
Right. Okay. And so again, you take blood to test levels that you think that's the gold standard.
Yes, and that's what's in the medical literature. So if you're trying to practice evidence-based medicine, I can give you 3 papers that show transdermal progesterone gives you no blood level, and oral micronized gives you great levels. And so if you're trying to practice evidence-based medicine, you can't be using urine and saliva levels for, the female hormones. You have to use serum levels.
Okay. Oh man. Okay. So when individuals, so we're kind of talking estrogen and progesterone right now. Why do we hear of a lot of women on testosterone when they're coming in with the same symptoms of hot flashes or lack of sleep? Why are they being led that direction?
So in menopause, you lose all of your female hormones, and testosterone is the dominant female hormone. We have more testosterone than estrogen when we're young and healthy. We've been conditioned societally and in medicine to say testosterone is for men, estrogen is for women, but actually testosterone and estrogen are for both genders. The female hormone is progesterone. And so women will be recommended to go on testosterone mainly for the diagnosis of a low sex drive. But testosterone will also lower their risk of breast cancer, improve their sleep, improve their body fat, lower their body fat, improve their mood. It actually helps treat anxiety, depression, body dysmorphia, OCD, anorexia. And so you have all these benefits. It help even improves cognitive function. So a lot of mom brain is you don't really ever reboot to your young testosterone levels. So it's a huge missing piece for women's HRT, but there are still some providers that are not convinced or they're using antiquated information we know that doesn't apply.
And do you have an opinion on a pellet versus like how would you be prescribing testosterone?
So I prefer to use either intramuscular subcutaneous injections or a transdermal cream. And that's because when you pellet it, if you happen to guess right, you in a perfect pellet world, you still only feel wonderful for half the time because either your levels are being building up or they're falling down. And you can put the same pellet in the same person and you can have different results depending on just subtle placement or how active they were for the pellet or how much exercise they did, their blood flow. And so you don't get consistent results. And if, let's say, I put a pellet in you and you hated how you felt, like your libido was through the roof and you were like, I need this out, it'd be very difficult to remove. So then you're
Mm-hmm.
stuck writing it out. And I don't particularly like the lack of control that comes with the pellets.
I can see that. That's interesting. Yes. Okay. Let's keep going down this line. Cortisol. When you have somebody come in, what would be some of your number one signs or symptoms that they're giving you where you're going, let's talk cortisol levels?
So in my experience, out of 1,000 patients with low cortisol, 999 will normalize their cortisol with optimizing their thyroid function. So
Hmm.
very few people have a primary adrenal problem. There's a lot of anti-aging groups and hormone therapy groups that believe that you have to treat the adrenal glands and then the thyroid problem goes away. But in my experience, it's the other way around. So I don't really have any patients that have abnormal cortisols after they've had their thyroid optimized.
Okay. So the individual who's going, I think it's my cortisol level, and I've been living such a stressful, like this would be like you being medical director at some point, like your stress levels up here, new baby on board, you still would be like, I'm not that worried about cortisol being the reason why your weight is stagnant or
It's
why
more so
you're.
that I think the cortisol is a symptom of an inadequate thyroid hormone at the tissue level, not hypothyroidism where your thyroid gland has been removed or destroyed. Rather, it's a T3 or an active thyroid signaling at the tissue level that's inadequate, that's causing the low cortisol rather than the low cortisol being caused by just chronic stress. Because we have a pathway by which chronic stress reduces T3 signaling directly. So I think it's more of a symptom of thyroid rather than a primary adrenal problem.
So then that individual who would probably tell you, I've had my thyroid checked. I'm fine. What
Yes.
would your response to them be?
So according to the guidelines for
Mhm.
thyroid hormone, which are written mostly by endocrinologists, and they say that you should only treat patients for hypothyroidism if their TSH exceeds a certain level. What that means is we should only treat patients once their thyroid has failed. So if you can imagine how good people would feel if we only treated their heart failure when they actually had heart failure and not when they had high blood pressure and diabetes, that would lead to heart failure. But the way that they've set up the guidelines and the way they set up the diagnoses is that they've set the definition of hypothyroidism. So most of my patients don't have hypothyroidism; they have hypoactive thyroid symptoms or low T3 syndrome. So their TSH is normal, but there's signaling issues at the tissue level, which causes cholesterol problems and diabetes and fatigue and cold intolerance and constipation, brain fog, hair loss, and all these things that are thyroid symptoms that will not get detected by a TSH.
So what should they be asking their provider who's telling them thyroid looks good? Like, what's the next digging question? This is one of the questions from our community is like, how do I be a better self-advocate?
You really are going to run into a brick wall if you tell your PCP, I think I need a better T3 level. There's a number of reasons for that. They don't realize that the normal range is not age adjusted automatically. So a T3 level for a 10-year-old is different than what a T3 for an 80-year-old would be, but it defaults to the older patients. So your T3 could be 3 and that's normal, but you're 21 years old. You should be able to have a T3 between 4 and 7. So unless that provider has the education, they're not going to prescribe you thyroid hormone. And even if they would, they're going to give you the T4 only, storage only product, which is Synthroid, which you are required to convert. And many people with this low T3 syndrome already have problems converting what they're already making. So those patients aren't going to feel better on the synthetic version. So they have to find a provider that's had thyroid training outside of conventional medicine.
Which typically takes you into an office that can get, again, like outside of insurance pay, right? Like, I
Mostly.
think this is a huge barrier for a lot of individuals, including myself. Just looking around here, my mom and I are ready to jump on a plane and come see you, honestly. But it's very difficult to for the person who does not have the means to go pay for some of these labs or see that provider. Like, what do you think next best step is?
There's some online groups where patients have gotten together. There's a group called Stop the Thyroid Madness on Facebook that has a few 100,000 people in it, and they've compiled T3 friendly physicians and providers across the US and in different countries. That's one route you can go. But I can say that I know colleagues that exist in the insurance system that know that this is good medicine. Insurance companies don't let you prescribe this way. Pharmacies aren't familiar with the older versions of thyroid hormone that we use that are more effective. And so
Hmm.
there's a lot of barriers you're going to run into, even if you can find a practitioner inside insurance. Even getting the prescription filled by a normal pharmacy can be a barrier. And then your insurance will often not cover it because they want to cover the synthroid, not the natural product. That's how good it is. There's all these walls up because it's that good at reversing chronic disease.
I feel like these moments, I love having these conversations and then I hate having these conversations because it still feels a little defeating. It kind of feels like maybe not everyone can get to the answer yet.
Yeah.
Do you, yeah, but thank you for mentioning the Facebook group because I think maybe the more and more that just the common person creates their own community or seeks their own community, we can again get to somebody within our own area too.
Yeah.
Ugh. So I love this about you. We talked about this in your first episode, but in your schooling, your professors, like for exam purposes, would take you through, like you had to actually say how a deficiency of something would affect a certain pathway and how that pathway would affect how something in your body's functioning. Like you truly understand every little pathway in the body, and it's so impressive. And I want to run our community back through this a little bit just to emphasize that if something is off and we're not fixing even something easy, like I was going to go vitamin D with you first, take an example like vitamin D and walk our community through what pathways that could be affecting or how that could be, causing some of these other symptoms that we're getting just from a vitamin being off.
Yeah, so vitamin D is interesting too because it's also controversial. So we're taught and trained in medical school that you have to be worried about vitamin D toxicosis, overdoses of vitamin D. And so our normal range goes between 30 to 100 in most lab ranges. And so most people are taught just get them into normal range and, that's it. Give them a low dose. What they don't realize is that there's actually a number of studies that show that the upper range of toxicity probably doesn't even happen at 400. And so there's a lot of room in this country, especially in the North Pacific Northwest and the Midwest, to be taking 5 to 10,000 units of vitamin D a day. And that's very well studied and very safe. But most providers will only give you 1,000 or 2,000 at the very most, some even only 400. So low vitamin D, if you think about high vitamin D is not dangerous, but what happens when there's low vitamin D? Low vitamin D is an independent risk factor for dying at a younger age, for heart disease, and for getting cancer, which are our big killers. And the upper range isn't dangerous and the low range is. So why not supplement so that you're at least in that middle of the normal range or upper range of normal? And we know that vitamin D is involved in the regulation of insulin secretion from the pancreas. And so you need adequate amounts of vitamin D in order to, especially if you're insulin resistant, in order to maintain normal physiology. You need it for bone health. It's implicated when it's low in anxiety and depression. And in women with PCOS, there's studies coming out that it actually lowers their glucose and insulin as well as their lipids, just vitamin D.
Wow. Okay, let's keep playing this game. B12. I know a lot of people walk in the doors and they might be like suboptimal. They're just sitting at the 300s of B12 and their doctor's like, you're good. What are our dangers of sitting there?
So B12 is obviously, and folate are both heavily involved in the production of your blood cells, like your red blood cells, etc. They're also important at the regulating the one carbon cycle, which basically swaps methyl groups in order to feed biochemical pathways with the right substrates. So if you have inadequate folate and B12, you can cause buildup of homocysteine if you have the right genetics. And homocysteine is extremely damaging to the vascular system and can incite an injury leading to plaque formation. So simply by supplementing B12 and folate, you can help reduce your homocysteine levels, which are another risk factor for heart disease. And a lot of people feel like they have more energy when they have higher B12 and folate levels. And there's really no downside as long as you're taking the methylated versions. So unless you know your genetics, you should pretend or assume that you have methylation issues, which many of our patients do, and take the methylated B12, so methylcobalamin, or the methylated folate, so that you're not in danger of having the metabolite of those B vitamins that you can't process because of your methylation issues.
And again, that would be for the common person, methylation. Like this is an absorption thing, correct? Like their body is not able to fully
Rather,
absorb.
the common example would be MTHFR, which is more and more you're hearing about it in podcasts and on social media, means you cannot methylate certain types of B vitamins. And so if you take the wrong B vitamin, it just sits there and builds up in your system and it's not doing its job and it gets in the way. And so it's not good to be on one of those synthetic B vitamins because you're actually worse off than taking nothing at all.
Hmm. Right. Interesting. Which is scary to think about too. Again, like if we don't have a way to check that out or know to ask.
Yeah.
Um, yeah, and I think it's interesting because again, living in more of like the weight loss world over here, when people have quick weight loss, a lot of times their B vitamins need checked. Like vitamins in general need checked when we're getting significant amounts of weight loss, and I don't feel like that's happening either. So here we are with a community that, is trying to get healthy and then can have things going low on them. Like, what's some of your talk around that with some of your weight loss clients?
So generally, most of our clients are hormone therapy clients and some of them also want to lose weight, if that
Yeah,
makes sense.
it
So we
does.
don't have that many patients that are just pure weight loss. And so when they go on hormone therapy, we generally suggest they supplement with methylated B vitamins, regardless of their starting levels, as long as their levels aren't already high because they're on a good supplement, in order to help facilitate their metabolic support, facilitate their energy levels. And as you know, also, those B vitamins, especially B12, are important with neurological function as well as the peripheral nervous system. So low B12 can give you numbness and tingling in your hands and feet, like diabetic neuropathy. So we try to fill up the tank so that we're not in a situation where they could possibly be getting low.
Mm, right. Okay. And then, I was going to ask, oh, clients walking through your doors. I agree. I could see that, yes, they're coming in for different symptoms, different reasons, but do you feel like a lot of them have a little bit of a hope that it will also affect the scale?
Yes. Yeah.
And do you see that? Or is it more like, okay, this is a piece of the puzzle and we need five other pieces or 10 other pieces to also be plugging in to see this other, weight loss component click into place?
There's probably some synergy, probably 1-2% better for the metabolic rate, maybe. But the effect of the hormone therapy and the dietary changes is so much bigger. But at the same time, we also don't want to be in a situation where they're developing a deficiency because let's say they've cut out all the grains and fortified foods out of their diet. Well, they don't have as much folic acid intake. We want them to get that folate from a methylated folate rather.
Okay, so question, when we think about people coming in, and am I separating this out too much in my brain as far as when I started to say, thyroid, cortisol, estrogen, progesterone, testosterone, like in my head it's all these different check boxes that like almost need ticked down to see if somebody's optimized. Um, are you looking at it that way, or is it just much more of like one lump sum? Like, am I separating too much?
Yeah, we generally when we do our consults, we are trying to get our finger on the pulse of their quality of life and trying to do a really broad review of systems to say, okay, what's your cognitive function? What's your sleep like? How's your sexual function? What's your metabolic health? And try to tease out all their symptoms so that when we get their labs back, we can say, oh, wow, they have terrible insomnia and night sweats and they're in menopause. They didn't know that yet. And they have no progesterone, or they have this horrible history of cystic acne and infertility, and their DHEA level is through the roof, even though they're 50, they probably have PCOS. So it helps us interpret the narrative history that we obtain, helps us interpret the labs for each individual patient and say, you know what, these are the 5 things I think that if we rebalance them, sort of like a symphony rather than one thing at a time,
Mm,
how we can get them their top priorities for treatment, which we ask them during the consult.
okay. And we've reviewed this before, but like you're very much symptom driven. You could look at lab work and fine, but you're really going off more of their symptoms, correct?
Yes, and I would say too, if tomorrow all laboratory investigations were unavailable for the next 5 years, I could still practice this medicine because we would still be able to gauge doses and responses, and we'd be safe at doing so because all of these hormones are part of the human body, and there are clear signs of underdosing and overdosing that would allow me to adjust things without needing the blood work.
Okay. So if a physician's telling their client, I don't trust the lab work, like this, they have their own protocol, they don't trust the lab work, you'd be like, the lab work doesn't matter. Like, then you're not listening to the symptoms.
Correct. And I would say the reason why they say the lab work isn't applicable is that they're using the guidelines. And I agree. The guidelines say you don't have a thyroid problem because they only count gland failure as a thyroid problem. I'm counting your greater thyroid system in your whole body as an actual reality because it's been proven to exist. And that thyroid stimulating hormone or TSH is not the be all and end all for all patients. They're just using it for diagnosing gland failure in the guidelines. And that's really all it can be used for. It shouldn't be used to guide treatment.
Okay, and then let's transfer this over into same thing like estrogen, or do they test testosterone? Can you, and are those all of them just very fluctuating depending on the time of the month?
Yeah, unfortunately, so in women, they base most normal ranges are based on a study where they took random 18 to 90-year-old women and they weren't on birth control. I mean, I don't care what my great grandma's testosterone level is because she stopped making it 50 years ago. So it's not evidence-based. So if you're outside or inside of normal range, who cares? We have a lot of studies to show when you're kind of 35 and up where you should be in order to have good sexual function. And then in men, they made the cutoff for hypogonadism in the guidelines, which means low testosterone. They based it on a Medicare database study. So they made elderly men the standard. And so you have to be worse than 95% of older men to be considered low, even if you're 40.
Hmm,
Again, it's not a good evidence.
right. It's just, I'm going to give you one more example because I feel like I have you in my back corner. Like I've listened to so many different podcasts. I've taken notes. I feel decently equipped. And I personally have gone into different physicians and asked because I feel like I have little symptoms that are starting and they're like, your lab works fine, you're like keep an eye on it. I've never had anybody actually want to help with the hormone piece of it. And I'm like, I don't even understand how anybody else has a fighting chance of attacking this.
I'm kind of disappointed because you think that with all the women going into medicine that maybe we could prioritize women's quality of life. But instead, it's just getting more and more like, oh, you have 3 kids, that's why you're tired. Or you can't sleep because you're postpartum. Here's an antidepressant, here's a sedative. The hormonal piece is so impactful. We just totally ignore it and say, and blame it on other things rather than addressing it. And we know that once you hit your 40s, that's when your antidepressant prescriptions go through the roof because you start developing symptoms of perimenopause. Well, I can treat that with progesterone. And I don't know very many women who wouldn't prefer to take a natural hormone their body used to make instead of a synthetic drug. Your body doesn't have a Prozac receptor, but it has a progesterone receptor.
Yeah, and again, we're working our way backwards in this episode. So I'm coming down now into the 40s, maybe even 30s for some, because I know some people start some of these symptoms earlier. But to your point, I have a lot of clients who they're like, my anxiety is so much ramped up from where it's been in the past. And to your point, put on an anti-anxiety or antidepressant. The depression's amped up since where it's been in the past. So it's not even mentioned to think of anything different than like, I think we just need some medication.
Right?
So it's frustrating. Like,
It is because those medications come with side effects. And
Mhm.
many of those medications will be addictive if they're, Klonopin and or benzodiazepine or Ambien for anxiety and sleep, they're addictive. And then the antidepressants can be impossible for some women to get off of. And so you're giving them this medication. I don't think they're having informed consent that this is something that they might not be able to get off of. And you could treat it with why don't you try progesterone first?
Mhm.
Most women would be totally fine with that because it's harmless. There's really no downside to it other than it puts you to sleep, which is beneficial if you take it at bedtime.
Right. Right. I have heard a couple of my clients that's like really working actually for the sleeping piece. So if somebody comes in to their regular primary or even their OB/GYN, and they request, like, I would like a bioidentical progesterone. I'd like to start with that first. Can you refer me out to a compounding pharmacist? If they could find the right verbiage, the right words, could they possibly be getting themselves to their own answer there, like kind of a self-guided
I,
session?
I, I wish that I had more faith in that strategy, but based on just my own experience with the healthcare system as a doctor, as a patient who is a doctor, as well as all the stories of all my patients. I'm not their first stop usually. They've already
Mhm.
tried to get help from many specialists,
Mhm.
rheumatologists, endocrinologists. No one could help them. And I think it's just a lack of understanding of this as a tool. So if you go to a plumber and ask them to put in a new electrical panel in your house, they're going to say, no, I don't do that. And so even though it's medicine, because it's not being taught in the medical schools, they don't have it in their toolkit. And they usually poo-poo compounding pharmacies. They say that they don't make good quality drugs, which is drug marketing from big pharma, because big pharma produces their drugs in third world countries and factories that don't get inspected for years, sometimes in towns with no running water. Compounded pharmacies get inspected regularly in person with no notice and have to adhere to all these very strict guidelines. So as long as you're getting it from a good compounding pharmacy, I think it's a cleaner product than what you are getting at your Walgreens or your CVS.
Oh, interesting. Thank you for that insight. That gives some comfort on if you can get into a compounding pharmacy with different options, a little safety net there. Yeah. Okay. So I have a couple, if you don't care humoring us, since you've
Sure.
been on in the past, we have some listener questions for you, and I thought we could kind of just toggle down through these. But one of them was the whole if a parent has struggled, I guess we've kind of already covered this, but if a parent has struggled with hormone replacement therapy, we really need to just take that with a grain of salt and assume that it was not bioidentical,
Yeah,
right?
so it was possibly underdosed, or
Underdosed.
the wrong route of administration.
Okay. And then another client asking on autonomy and choice. How can we feel more in control and confident about our choices, which you and I are starting to talk about as well with hormones, and feel less afraid to advocate for ourselves? Any nuggets that you can give us to be like, this is how you can walk through the door or
Yeah, I
who to
think
go
it's important for you to have a clear list, maybe even if you write it down ahead of time, of like, these are my priorities. I want to lose weight. I'm tired of having night sweats, and be able to communicate clearly to the provider, like, I do not want the standard of care. I don't want what's in the guidelines. I want an alternative. And
for.
be willing to walk out of that office with nothing rather than settling on the thing that you don't want. So don't accept a prescription for an antidepressant if you're there for progesterone. And you might have to go through a few different providers to get to someone who's willing to listen to you. And the more information you can glean, the better. So educating yourself through books or podcasts is very helpful. Although I would say there's a lot of noise that isn't evidence-based in this industry.
Right. I know, I hear you. You still have to be wise where you grab your information, right? Yes. Ugh, so we keep talking about the antidepressant versus the progesterone, but what about, I know birth control is also offered quickly. Can you go into that again for a moment?
So birth control, oral contraceptives are generally composed of a synthetic estrogen combined with a synthetic progestin. And so they're anti-progesterone. So they feed back to the brain and reduce the function of the ovaries so that you reduce ovulation. You don't grow the lining that's required to gestate a pregnancy. It makes the cervical mucus a little different, the intrauterine environment, so that you're lowering your risk of pregnancy. And when you're in that state, you actually are blocking progesterone receptors. When you block progesterone receptors, you increase insulin resistance, visceral fat, glucose, lipids. This is all in the drug monograph for birth control. And they get away with saying it doesn't cause weight gain because they like to do 2-month studies where the scale didn't move, but their body composition changed and they became fatter with less muscle because it
Hmm.
blocks your testosterone. So when you're on an oral contraceptive, you're shutting off the ovaries, so you're muting you're lowering your hormone levels. They also like to say that it tricks your body into a pregnancy state. Well, in pregnancy, when I measure pregnant hormones, estradiol levels like 6,000, which is, I don't know, 30 times what you are when you're not pregnant. Progesterone's 500, which is 100 times higher than when you're not pregnant. And so in your pregnancy state, you have high levels of hormones. When you're on birth control, you actually are suppressing your hormone production. And sometimes that will help with acne. Sometimes that might help with helping your periods. But there's some consequences to that in terms of Neuropsychiatric symptoms increase because you're blocking progesterone. So a lot of women will end up on an antidepressant. Weight gain, low libido. There's other studies that show it changes your sexual preferences. So you'll be attracted to a different type of man or woman than you would be if you were not on contraceptive. So
Interesting. Never heard that one. Okay. And then while we're saying this, because I know a lot of women go in with extra heavy flow, and then they are put on the birth control just for that. So same thing, like we're muting something versus taking a more curative route with it. Am I understanding that right?
if I could have enough time, I can put women on enough progesterone that their dysfunctional bleeding will go away or become very minimal without needing to have surgery or like a hysterectomy or an ablation or going on an IUD or a contraceptive, an oral contraceptive.
Okay. So it can be avoided. Like birth control it kind of sounds like needs to be avoided.
Well, if you're on birth control because you need to be on it to prevent pregnancy, that's really the only indication where progesterone doesn't win. Because if it's for heavy bleeding, endometriosis, painful periods, PMS, PMDD, I can use progesterone and I'll get rid of those symptoms. And then if it's for acne, I can use thyroid hormone and vitamin D, and that will usually take care of most acne. And so
Hmm.
then you're really just left with, okay, if you don't want to get pregnant, that's really the most reliable way. But there are consequences.
This is so interesting because I feel like so no matter what somebody comes in with and provides symptom wise for you, I can just see your little internal wheel sticking away going, nope, we'd go this way. We'd go progesterone, we'd go testosterone, we'd go estrogen. And very rarely do you go any other medicine direction. You really go hormones on everything, yes? Like, is there
That's our
much
main
that,
focus. Yeah. So if somebody,
yeah.
I have some people that just do a consult because they just want to have a provider look at their labs in detail and they go on their way. They just do like a quick checkup. Everything looks great. Keep doing what you're doing. Other people are there because they have quite a lot of symptoms, at least 10 or 20 significant symptoms that are impairing their quality of life. And if they wanted the standard of care, they would have gotten it 10 years earlier with their PCP. And so they're at our office because they want an alternative. And if I were to see an adolescent who, let's say, had terrible PMS and periods, if she wanted birth control, I would say go see your PCP because they can do that for you, no problem.
Right, right. At this point, they're asking for something different out of you. And you even mentioned like eating disorders, anorexia, that do you feel like within an eating disorder clinic, they should also be testing hormones?
Probably. One of the things that happens when you have severe calorie deprivation is you produce reverse T3, which is an anti-thyroid hormone that blocks your thyroid signaling at the tissue level. And that's why a lot of these ladies and men will actually become obese later in life. Their metabolic rate got severely damaged from the starvation. There's actually studies where they give women with anorexia additional testosterone and their body dysmorphia improves and they can eat.
That's unbelievable. It's just all these little layerings that are, again, unknown. This is kind of jumping into a different topic, but with staying on a hormone way later on in life, 70s, if somebody stays like never lost their period, never fully went into menopause, and they go on hormone replacement therapy, will they continue a period as long as they're on hormones?
So
No.
once you're in you can't use estrogen replacement until you're definitively in menopause. But for the first 2 to 3 years after menopause, you can have some residual ovarian function. You can have 2 or 3 more periods, which is normal. But if you have persistent bleeding on continuous progesterone and estradiol, that's lasting 3 months, more than 3 months, I should say, after you've adjusted estrogen or started estrogen, then you may have a uterine issue where your lining might be precancerous or cancerous. And then you would have a workup for that. But really, you should not be cycling your hormones because the days that you're not on the hormones are the days you're not protected metabolically and your bones aren't protected. You want to be on them continuously with no period.
Gotcha. Okay, so if somebody's in their 40s and they're just starting to get symptoms of perimenopause or whatnot, they're really not going on the full replacement yet.
Correct. So they're in that time period where their inhibin levels, which control estradiol production in their ovaries, become dysregulated, and their estradiol levels are actually high, which is why they feel bloated. They get more acne and mood swings and bleeding. And you counteract that with high doses of progesterone, they can feel quite normal in their 40s. And then at some point, their ovary will just stop working. Usually, I found that on my blood work in some of my patients who I've been treating for a few years. And then we start estrogen, and they were never really deprived of estrogen longer than a couple of months, usually.
Okay. For the person who is full menopausal and going, I still get that time of the month that I'm extra hungry or irritable or whatever. Is that a real, is there medical reason behind that?
I haven't heard that too often from patients, but I will say I have heard it from some that they do feel like they have an internal cycle. I'm not
Mhm.
sure what that is, if it's a residual like memory from when they were younger, that they still have that cyclical experience, but they're once you're in menopause, your ovaries aren't producing those hormones anymore. So there is no cycle. If you take your hormones the same way every day, you'll always be the same level.
Okay, that's so interesting. Yeah, I've had two people ask recently, like, why am I getting these cycles in the middle of the month and I'm
Yeah.
60 or I'm 70? Okay, I think that we have hit what I thank you have been wanting to hit. What am I not asking that you wish our community would hear today?
Let me think. I would say that I wish that more of your audience that are providers themselves and nurses and physical therapists, people in the healthcare system, those are the most important people to go get themselves educated in this area because they're the ones that can advocate the best for their patients. So we see in the emergency room all the time these people coming in with horrible constipation, you know, acute abdominal pain from infected gallstones, high blood pressure, and all of these conditions that could be prevented through hormone replacement therapy. And if there was a greater awareness in the medical community, our patients would have better access.
Thank you. Um, and we could have access to you, correct?
Yes.
Depending on where we live and a one-on-one, like describe that again, that we would need to see you in person first, and then you can do more virtual care.
So the law for testosterone under the DEA is extended for 2025. So currently everything can be done by telemedicine. Although when they change the law, it might be that future patients have to travel for their first visit or one visit in person before they can get testosterone. But if they're in a state that I'm licensed in, progesterone, thyroid, those are all not controlled. So those can be done purely by telemedicine.
Okay. And you do like a discovery call or you do an initial consult
Oh, yeah.
where, okay. And that will all be in the show notes. We'll put links to everything in the show notes. And you had also mentioned World Link Medical is like was your first introduction, correct, to your aha moment with all of this?
Yes. Mhm.
Would it benefit the like non-medical person to ever go into any of these trainings? I know they're not super cheap, but they
Yeah.
are interesting.
Yeah, if you're not a prescriber, they're actually significantly less money to attend. And we do have members of the public that do attend them. And I think they are digestible enough that you could understand a lot of the meat and potatoes of the content without getting too lost in the medical literature that's presented.
I saw that they have something coming up soon and then also later in the summer. And I was thinking that would be an interesting because it was in person as well as they do a virtual opportunity with it. So there are resources. We just need to know that they exist, right? And then say yes and take advantage of them. Yes. All right. Well, again, thank you so much for coming back on. If you could leave us with one last wrap your arms around these women and give them a little hope that what would you like to send them out with to give them that hope?
I would say that trust your own intuition and your own internal knowledge of your body and how it's changing. And don't take no for an answer. If you feel that you have a hormone problem, you're probably right.
Okay. I love that. Thank you, Dr. Lovett. You're amazing.
Problem.